finally competing against Labor Weekend with 2 talks on heart failure, including epidemiology and pathophysiology and acute heart failure. So please bear with me. I know some of you heard me give this talk probably 4 or 5 times. I won't call on you, but I know who you are. So, please let's make this more interactive than didactic. So if you have any questions, please, feel free to interrupt me, and I'll try to make it as painless as possible. But definitely, we have to go through some basic concepts. We have 2 lectures today, and then I believe next week I'll come back and we'll talk about chronic heart failure. Today, the first topic will be the basics. The second topic will be acute heart failure. Every slide I have, you can give a lecture on. So I'll try to give you a teaching point of every slide I see. And again, please interrupt me if you have any question. And let's make this relevant. This is not working. All right, so we'll do this. Well, that's fine. Here we go. All right. So this is just basically to disappoint you that I don't have any case studies. So in case you were expecting that, maybe we'll do that next week. So, all right. So we'll go over some definitions of heart failure, the epidemiology, a couple of slides on historical models, how we got here in terms of the basic understanding of heart failure. We will talk a lot about the neurohormonal axis, the Renin-Angiotensin Aldosterone axis, sympathetic axis, and finally cardio-renal interaction. So heart failure is a syndrome. It's not a disease. It's characterized by elevated filling pressures, pulmonary and or systemic, resulting in inadequate oxygen delivery and inadequate oxygen extraction at the periphery. Heart failure is a dynamic condition. Patients can have systolic dysfunction for years and not have symptoms because of compensatory mechanisms. Once heart failure is manifested, then it's a progressive disorder, and it is a condition where compensatory and adaptive mechanisms can turn into maladaptive mechanisms. If you look further into the subcategories of heart failure, you have the 2 major basically classifications. One is heart failure with reduced ejection fraction, or systolic heart failure, and the other one is heart failure with preserved ejection fraction, or diastolic heart failure. HFrEF, or heart failure with reduced ejection fraction, is the clinical syndrome characterized by signs and symptoms of heart failure, i.e. elevated filling pressures and reduced cardiac output. It is most commonly associated with dilated ventricles, as we see in end-stage ischemic cardiomyopathy or idiopathic cardiomyopathy. On the other hand, HFrEF, or heart failure with preserved ejection fraction, has the same clinical syndrome. So patients come to you with elevated filling pressures and plus minus low cardiac output. However, the geometry is one of normal sized ventricle, a non-dilated, usually thick geometry. And this is the index case for this type is hypertension. But you can also see this with valvular heart disease. You can see it with infiltrative cardiomyopathies. It is very important to understand myocardial remodeling as a precursor for heart failure. And myocardial remodeling obviously is a bad thing. It's characterized by pathological changes of hypertrophy, whether concentric or eccentric hypertrophy, as a result of pressure or volume overload. And I have a couple slides to show you the difference. These changes are progressive, and they lead to clinical manifestation of heart failure. So in order to understand ventricular remodeling, you need to understand the normal shape of the myocardium or the ventricle, and it is usually elliptical. It's football shaped, and it's that because it reduces the stress and strain on the ventricular wall. Contrast that to ventricular remodeling in end-stage cardiomyopathy, where the ventricle is now more spherical, dilated, enlarged, with significantly elevated wall stress and strain. So again, simply, ventricular remodeling is going from a normal elliptical shape to a spherical, enlarged, and dilated ventricle. And again, side to side, you can see the difference between HFrEF or low EF heart failure and HFpEF or preserved EF heart failure. Its size and the dilatation of the ventricle. But notice that the symptoms are the same. Congestion plus minus low cardiac output symptoms. So again, that becomes important when you talk about therapeutic options. Now, I want to make it clear that ejection fraction is not a measurement of contractility. And the next few slides will prove to you that you cannot rely on ejection fraction to determine the stroke volume, nor that you can rely on ejection fraction to determine the cardiac performance or the cardiac output. The myocardium, the heart, is a volume displacement pump. So you're basically starting from a set point, which is the end diastolic volume, and then you're ending with the end systolic volume, resulting in a stroke volume. How we get there is because we have good longitudinal shortening of the myocardial fiber and radial as well as circumferential shortening. So the ventricle goes from the base to the apex along the longitudinal axis. So that's how you displace volume. It also shortens across the radial axis, and of course you have the apical impulse, which is a result of a torsional force of the ventricle moving circumferentially. So this is how the volume displacement model work. Now, when you talk about ejection fraction is really a measurement of size. And when you measure ejection fraction, you are measuring the end diastolic volume. The greater the end diastolic volume, the lower the ejection fraction. Stroke volume can be normal, can be low, can be high, and you can have low ejection fraction. For example, you can have very small stroke volume and very small end diastolic volume and have low ejection fraction. You can also have normal or high stroke volume and high end diastolic volume and have normal ejection fraction, so on and so forth. You can imagine the combinations here. So you can have low EF patient who has dilated cardiomyopathy but have preserved contractility. On the other hand, you can have preserved ejection fraction, thick ventricle, small end diastolic volumes, and because of that, you can have small stroke volume. However, you have normal contractility. Now, I know I confused you, and I intended to do that because I wanted you to know that you cannot just look at ejection fraction and say, well, this patient has low cardiac output failure. You have to go back and figure out what is the end diastolic volume, where are we starting from? Are we starting from high end diastolic volume, therefore resulting in low ejection fraction, or do we have a normal end diastolic volume, therefore ejection fraction is preserved? And the only way to know that is to look at the phenotype of heart failure. In other words, look at the echocardiogram, look at the history, and go from there. So this is another way of representing ejection fraction versus contractility. Ejection fraction is not a measure of strength or cardiac performance. It's a measure of size. It's how big the ventricle. The lower the ejection fraction, the bigger the ventricle. Now, so where did we come with this fascination with ejection fraction? Well, it's from the epidemiological data, such as this study, showing that if your ejection fraction is low, your mortality rate is higher. So ejection fraction is important. It confers increased risk. It's a negative prognostic indicator. However, it's not synonymous. It's not synonymous with cardiac output. Not always, anyway. moving on in terms of laying out the definitions and the language of heart failure. The ACC came out with staging system that looked at heart failure as a continuum from stage A, where you don't typically have the manifestation of the disease, but you have risk factors to develop the disease, such as hypertension and diabetes, all the way to stage D, where you have end-stage disease, patients having the burden of the symptoms on a daily basis, patients are being evaluated for transplant or mechanical support. Of course, the most common stage that we see is stage C, which is your garden variety of heart failure patients who do fine with outpatient management, occasionally be admitted to the hospital, but then go back to be compensated. Stage B is previously known as asymptomatic left ventricular systolic dysfunction. So this is structural remodeling, whether it's hypertrophy or dilatation, however, without symptoms. If you have stage C or stage D, then you can move on to describe the functional status of your patient using NYHA classification. And the NYHA classification is the oldest classification that we have. It has many limitations. However, it's been used in many clinical trials to devise many treatments that we use for heart failure. So it's well validated. And class 1 is your patient who will not have any symptoms, provided that the patient is actually active and able to do things. Class 4 is when you have symptoms at rest, and of course class 2 and 3 in between, class 2 being symptoms on moderate exertion or ordinary activities. Class 3 is if you have symptoms on mild activities. Now, in addition to describing the stage of your patient and the NYHA classification, you should be prepared to assess the volume status. And any assessment of your patient, whether it's outpatient or inpatient, if you go with this scheme, the staging, ACC staging, the NYHA class, and the volume status, you can then easily devise your treatment, whether it's diuretic therapy or optimization of neurohormonal therapy. So your patient can either be euvolemic, hypervolemic, or volume up, volume down, or hypovolemic, or what I call optivolemic, which is when the filling pressures are high, however, the patient is compensated. And when you're unable or have not been able to push diuretics, fearing hypotension or worsening renal function. And of course, you can say, who knows? You can do all the clinical examination and diagnostic testing, and you're still at loss. And that is important, as we will see in the next lecture on acute heart failure. We use surrogates for volume. I mean, we use pressure, i.e. JVP or wedge pressure, as a surrogate for total body volume. And that can be very tricky because it's not a linear relationship. And we'll get to that in the next lecture. Any questions so far on the definitions? Systolic, diastolic, or HFrEF, or heart failure reduced ejection fraction, HFpEF, heart failure preserved ejection fraction. I know it's mouthful. And then the staging, stage A, B, C, and D. Most common one is stage C. D is end-stage heart failure. And the NYHA classification. And then finally, the volume assessment. Yes? Well, that's a very good question. Heart failure is a clinical diagnosis. So you must have clinical evidence of low cardiac output and or elevated filling pressures. It's not an echocardiographic diagnosis. It becomes tricky when the EF is preserved. If EF is low and patient's having symptoms, then that's straightforward. The patient has heart failure, manifesting clinically and then echocardiographically. When you have preserved ejection fraction and the patient has COPD and arthritis and functional limitations, and then it's reported that the patient has diastolic dysfunction stage 2. How do you do this. And it's not easy, and no guidelines on this. The European guidelines, however, do mention that you have to have at least biomarker evidence of heart failure, say BNP greater than 500, along with symptoms that are specific for heart failure, such as orthopnea or signs such as S3. So the point is, don't just rely on the echo to make the diagnosis of heart failure. And the business of saying someone has heart failure stage A is a tricky one too. I mean, although it's in the ACC staging system, I wouldn't put this on the chart, because then your patient won't get insurance. Then, stage B, maybe I would say LV systolic dysfunction, and I would be very careful with heart failure. Heart failure is a very scary term. I mean, if you counsel your patient on heart failure and they have it, it's scary enough, let alone if they have just a asymptomatic case of it or borderline. So that's a long answer to your question, but it's a very important question. All right, so epidemiology. If you look over the past 20, 30 years, the incidence of heart failure is on the rise, and this is because now we have beta blockers, we have good prevention of sudden cardiac death, we have elective coronary revascularization, so on and so forth. So patients are living longer, and they have wore-out hearts, and we're seeing more and more heart failure. And it's very common in the elderly. And one out of 10 patients age 80 and older will have heart failure. So it is common. There is disparity in terms of the incidence of heart failure across races. So heart failure is most commonly seen in African American males. And there are many reasons behind that. But it is important to recognize this health disparity, because something can be done about it to prevent it and improve access to care. It's a very costly condition. It's almost $40 billion to care for heart failure. And it's a deadly condition. 5-year survival is less than 50%. In stable heart failure patients, outpatients, 1-year mortality is about 8%. Immediately following hospitalizations, 1/3 of patients will die with heart failure within 1 year. Heart failure, actually, advanced heart failure is, the prognosis of advanced heart failure is worse than pancreatic cancer. So, I hope I was able to convince you that heart failure is a very important condition and deadly one. All right, so moving on to some basic concepts. Again, trying to understand why you develop heart failure, how it progresses, and what are potential therapeutic strategies. So I know all of you are very anxious to delve into pathophysiology. Keep in mind that the syndrome of heart failure is the end result of many underlying predisposing factors, such as hypertension, left ventricular hypertrophy, and, for example, genetic predisposition. There's always an index event that led to drop in the LV performance, or the pumping force of the ventricle. That can be postpartum cardiomyopathy, can be idiopathic, or long-standing hypertensive overload or pressure overload. The body, however, has an incredible way of compensating for that, mainly through the neurohormonal axis, which we'll go over in a minute. And for years, patients can be asymptomatic and compensated with EF of 15-20%. I saw a patient just a couple of hours ago who comes in, he's 65, never been to a primary care physician in the past, and has been doing great. All of a sudden started having bronchitis and asthma, and you know, when heart failure specialist is dealing with bronchitis and asthma, what that means. And basically was prescribed an antibiotic, and he is fixated that the antibiotic that he took 2 weeks ago is why he has a 9 months pregnant belly and, anasarca and orthopnea and cough and all of this. And I tried to explain to him that his ejection fraction of 10% didn't just start 2 weeks ago. It was maybe 5 years ago or 10 years ago. You have to understand how we develop cardiomegaly and hypertrophy. There is a reason behind that. The ventricle is programmed to reduce wall stress. And if you remember Laplace law, where wall stress is proportional to the pressure and the radius and inversely related to the wall thickness, then you can understand why there is ventricular hypertrophy. It's trying to compensate for increased stress, such as the ventricle encounters in untreated aortic stenosis or long-standing hypertensive pressure overload. The pressure is increased, and the only way to compensate for that is by increasing your denominator, by increasing wall thickness. And that's why we develop hypertrophy. Now, this hypertrophy can be concentric hypertrophy or eccentric. Depends on when this pressure overload occurred. During systole, such as in aortic stenosis or hypertension, or during diastole, such as in volume overload conditions, such as mitral regurgitation. Either way, this pressure overload or volume overload is going to stimulate the stretch receptors, and this is going to produce growth signal, and you're going to have hypertrophy either in parallel, meaning that you have your sarcomeres lined in parallel next to each others, producing this thick concentric ventricle, or in series, producing this very large flabby ventricle. I'm going to spend a couple of minutes on this slide, which will help you understand why we are so obsessed with ACE inhibitors in heart failure, why we're so obsessed with aldosterone antagonist and beta blockade. It all starts when you have low cardiac output. Low cardiac output results in low blood pressure. When you have low blood pressure, you unload your mechanoreceptors. We all remember this from physiology. It's a feedback mechanism. If you have high pressure, you inhibit sympathetic output. If you have low blood pressure, you stimulate sympathetic output. As simple as that. Think of it this way. If you're lost in the desert and you don't have any water and your blood pressure is low, you want your mechanoreceptors to respond to low blood pressure by producing more neurohormones, such as aldosterone, angiotensin II, vasopressin, because you want vasoconstriction, you want sodium reabsorption, water reabsorption, so you can maintain and protect your circulation. And that's exactly what happens in heart failure, except it happens over months and years. And it turns from, again, compensatory, adaptive, good mechanism to restore intravascular volume and central pressure to maladaptive, because now angiotensin II is acting not only as a vasoconstrictor, but as a growth hormone. Sympathetic drive is causing tachycardia and supply-demand mismatch and energy deficiency, so on and so forth. Aldosterone is leading to interstitial fibrosis. So see, a good compensatory adaptive mechanism is turning into maladaptive and bad homeostasis. Is that clear, how we go from compensation to decompensation in heart failure? Any questions on this? All right. So going through some historical models of our understanding of heart failure as a syndrome. The oldest model is the congestive model, and that's when the only available treatments for heart failure were digoxin, dating back to 200, 250 years ago, and diuretics, which again 200 years ago were mechanical diuretics, and I'll show you that in a minute. So basically bloodletting was the only way you treat heart failure. You remove intravascular volume and you reduce filling pressures that way, and it actually worked. Then we moved on when we were able to do heart catheterizations dating back in the 1920s and 30s. Then we became fascinated with pressures and wedge pressure, and we then developed vasodilators in the late 70s, early 80s. And we decided that heart failure is now is a pump problem, is a backward failure, forward failure, leaky pump, all these analogies, which is good, and it's important to understand it in order to devise, good treatment for your congested patient at rest or a patient with low output. But this model does not help you understand why on earth beta blocker, which is a negative inotropic agent, would be helpful in heart failure. If we're stuck at that model of pumps and pipes and hemodynamics and congestion, then we wouldn't be using aldosterone antagonists or beta blockades. Definitely not using beta blockades because we're giving negative inotropic agents. So there must be other models, and I'm referring to the neurohormonal, molecular, and cellular models. And in the next few slides, I'm going to go over the neurohormonal model and why that is important in the management of heart failure. Again, these are basic concepts. I'm not going to review any medical therapy. We'll do that next week. So the renin-angiotensin-aldosterone system, we all know that angiotensinogen is produced by the liver and is cleaved by the renin, which is produced by the kidneys, to produce angiotensin I. Angiotensin I is then converted into angiotensin II through the angiotensin converting enzyme. And angiotensin II is a bad player because angiotensin II causes vasoconstriction, it causes release of aldosterone, it causes apoptosis, so on and so forth. So angiotensin II is a bad player. It's a ubiquitous protein. It affects many organs. But in heart failure, we're mainly interested in what it does to the myocardium and the vasculature. Now, experiments were done in the past to prove that patients who have either asymptomatic heart failure or symptomatic heart failure have higher levels of renin than patients who have normal hearts. As simple as that. So this experiment was elegant. It shows that if you have heart failure, you have high renin. If you have high renin, you have high angiotensin II. And we're assuming that high angiotensin II is associated with progression of the disease, therefore management of the angiotensin system, the RAS system, the renin-angiotensin-aldosterone system, will result in a better outcome. And I'll have the data to show you next week. Furthermore, if you take a patient who is adequately treated with angiotensin converting enzyme inhibitor, or ARB, and you study their aldosterone level, you would think that if you completely block the production of angiotensin II, then you will basically get rid of all the aldosterone that you can get from the adrenal gland. And that's actually not true, because if you see here on the horizontal axis, we go this way, it means that you have blocked all angiotensin II production. This way, it means that you have loss of angiotensin II activity available. On this axis, the higher we go, the higher the aldosterone level is. So most patients, if we have blocked their aldosterone through ACE inhibitor or ARB, should be in this category. However, you see that there are many patients who have still high aldosterone level despite the fact that they have been blocked with ACE inhibitors. This is what we call the aldosterone escape mechanism. I'm showing you this slide basically to make the case for using aldosterone antagonist in someone who is on ACE inhibitor and ARB. So next time you're faced with someone with a little bit of high potassium and you're unable to add spironolactone, and you may tell yourself, well, the patient is already on ACE inhibitor and ARB, why do I need to obsess with spironolactone? You need to remember this slide because it shows you that you can never completely obliterate aldosterone production. And of course, I have to put a next slide after that to demonstrate to you that aldosterone is bad, is a bad player. And what I'm showing here is that when you have excess aldosterone, your end diastolic volume is high. So you have more dilatation, you have more remodeling. You go from the elliptical shape to the spherical shape of the ventricle if your aldosterone is high. As simple as that. And again, elegant experiment that showed you that aldosterone is bad. And of course, I can show you many slides how aldosterone acts as a fibroblast growth factor. It causes fibrosis, sudden cardiac death, so on and so forth. Now, vasopressin is a very important player in heart failure. I'm sure many of you have seen heart failure patients with hyponatremia, and you don't know what to do with this patient. Is it euvolemic? Is it hypervolemic? Is it hypovolemic? How do you treat it? You give them, you replace sodium. You push ACE inhibitors. You give them inotropes. Well, you need to first understand what causes hyponatremia in patients with heart failure, and provided that your patient is not truly volume depleted or significantly volume up, the mechanism of hyponatremia in heart failure is excessive vasopressin release. Vasopressin or ADH is released in response to thirst, but in heart failure it's released in response to angiotensin II. So the worse your heart failure, the more stimulation of the hypothalamus and the more production of vasopressin, and ADH is going to make you retain water, and you're going to have dilutional hyponatremia. And this is a slide showing you that the level of vasopressin in subjects with heart failure, the levels are elevated, and it's associated with worse outcome. All right, moving on to the sympathetic axis and discussing beta blocker. But before we do this, any question on the renin-angiotensin aldosterone axis? Again, it's activated because your mechanical baroreceptors have been unloaded, low central pressure, compensatory mechanism to begin with. However, it leads to cellular damage down the road because of unopposed activation. All right, so sympathetic activation. Now, you can understand why we like beta blocker in cardiology in general by looking at this slide. This is an elegant observation showing you that the higher the heart rate, the lower the life expectancy. So rats are unlucky because they have basically heart rate that is almost 300 beats per minute with life expectancy of 5 to 10 years. We are right here, so we're kind of like in between. But that's just an elegant way of looking at myocardial energetics and how we can save that heart rate reserve that we have. I have shown you levels of angiotensin II, levels of renin, levels of vasopressin, and I'm going to show you levels of norepinephrine. And maybe I'm stating the obvious here that if you have myocardial failure or cardiomyopathy, you have low cardiac output, then your endogenous norepinephrine release is going to be higher, trying to restore the circulation. This is all what I'm saying. And I'm showing here that not only your baseline level of norepinephrine is elevated, so your resting norepinephrine level is higher in patients with cardiomyopathy, but also the spillover. So in response to exercise and stress, your norepinephrine goes up. It is important to understand that because that's how that's why we use beta blockers in these patients. The following slide is showing you that if you have high norepinephrine level, you have less probability of survival. So again, inverse relationship between norepinephrine level and survival in heart failure. The state of excess catecholamine in heart failure has detrimental effects on the heart through these mechanisms. Sinus tachycardia, peripheral vasoconstriction, i.e. increase in afterload, decreased diastolic filling time, so filling failure, and of course increased afterload. The positive inotropic effect, I listed it under bad effects, is because it's a state where you need more energy. So you're tapping into the myocardial reserve, and that leads to ischemia. When you have excess catecholamine stimulation in heart failure, you will have a negative feedback mechanism of beta-1 receptor downregulation. And I'll show you a slide in a minute. This is essential to understand if you want to, this is essential to know if you want to understand why we use beta blocker in systolic heart failure. How on earth we use negative inotropic agent to treat a negative inotropic state. So you need to understand first that if you have excess catecholamine release, you have so much norepinephrine floating in the system, the myocyte respond to that by desensitizing the beta receptors and internalizing beta receptors. In a way, the myocyte is hiding from that excess norepinephrine stimulation to prevent myocyte death and apoptosis. Because you desensitize these receptors and you internalize the receptors, you created a state of negative inotropy here because you don't have enough coupling of receptors with norepinephrine. So I'll show you that in this cartoon. This is the myocyte beta. This is the beta receptor on the membrane, cell membrane. You see how with excess norepinephrine, you uncouple the receptor from the subcellular signaling process. And any stimulation of the receptor now does not lead to increased calcium and increased inotropic state, but it leads to cell death and apoptosis. So you have a combination of reduced number of beta receptors, and then the number that is left, the beta receptors are eventually linked to norepinephrine, are actually resulting not in myocyte contractility, but in myocyte death. Is that clear? So you have too much norepinephrine, the receptors are hiding from that norepinephrine by downregulation, and then the few left receptors are being stimulated to produce adverse effect. So beta blockers were contraindicated when I was a resident. They were contraindicated. They were not in the guidelines. It was back in the 70s, however, that a Swedish group actually wanted to give beta blocker to acute heart failure patients. And that was then considered to be really, they're out of their minds. How do you give beta blockers to people who come in with acute MI and acute heart failure? Back then, they thought that simply if they're tachycardic, their myocardial oxygen demand is up, give them beta blockers, slow the heart rate, improve the myocardial energetics, and that's how you improve outcome. They did not understand the basic molecular biology behind giving beta blockers. Now, 35 years fast forward, we know why beta blockers work in heart failure, because what we're doing here is we are withdrawing that norepinephrine support. We're doing it very slowly, using small doses and slow up titration. So if you take that state of excess norepinephrine and you give beta blocker, you reduce the central output, you reduce the adrenal gland output, the spillover, and now you create a reverse state of low norepinephrine release or low adrenergic stimulation. The myocyte will interpret that now, the reverse to the state of cardiomyopathy. It will interpret this as reduced adrenergic support. Now it's going to upregulate beta receptors. You're going to have more beta receptors, and these beta receptors are actually good beta receptors that are linked to good subcellular signaling process. So you went from excess norepinephrine to relatively less norepinephrine by giving beta blockers, which kind of tricked the myocyte into producing more beta receptors, the good beta receptors. And that's why in patients with catecholamine-induced cardiomyopathy, such as tachycardia-mediated cardiomyopathy, we can reverse this cardiomyopathy. And their ejection fraction, i.e. the size of the ventricle, can go from 20% to 50% by simply pushing beta blockers. Is that clear, the concept of beta blocker in systolic heart failure? Don't think of it as a hemodynamic intervention. It's not a hemodynamic intervention. It's a molecular intervention. It's a cellular intervention. And it is important that I am going over all these boring basic concept themes, because next time your patient comes in and the patient is on beta blocker and they come in and they have acute heart failure, you're going to struggle. You're going to say, well, the patient's blood pressure is 95, they're on beta blocker and they have heart failure. I should reduce the dose or stop the medicine. And I would encourage you not to do that. Now that you understand that there is a difference between the pharmacological effect of beta blocker, the one that we like to see on the coronary unit, in someone who has acute MI, We want to slow the heart rate. We want to reduce the blood pressure. But what you're going after in heart failure patient is actually not the biological effect. It's not the pharmacological effect, but rather the biological effect. It takes months to change the milieu, the density of the beta receptors. And if you stop beta blocker, you're going to actually worsen the condition, because now all of a sudden you're overwhelming the myocyte with norepinephrine, and you're going to downregulate beta receptors, and you're going to actually produce a negative inotropic state. Is that clear? So withdrawing beta blocker here ironically produced negative inotropic state, because you have reversed all the biological alterations that you made with beta blockade. All right, the last couple of slides on cardio-renal pathophysiology. And, you know, we always have back and forth with the nephrology colleagues, and we all just one body, I know, we all one, you know, one environment. However, this cardio-renal interaction is problematic. You know, these patients are sick. You know, you give them treatments to improve their congestion, but then you're forced to stop your treatment because creatinine is inevitably to go up. Now, what is the conventional wisdom when it comes to cardio-renal interaction? And I may maybe 3-4 minutes over time, and I'll compensate for that for the next lecture. But the basic understanding of the basic concept of cardio-renal syndrome for 100 years has been that if you have low cardiac output, your blood pressure is low, your kidneys have been getting less blood pressure, your renal perfusion pressure is low, your GFR is low. As simple as that. Makes sense, logical. The only thing is, it's not always correct, and you need to keep that in mind. And it's not always correct because data doesn't support it. And I'll show you that in a minute. So instead of this model of low flow state hypothesis, there are alternative models, you know, that look into the renal vein congestion, intra-abdominal pressure, sympathetic overactivity, cytokine mediated renal dysfunction, so on and so forth. But the reason why this model is not always correct is because if you look at this data, for example, and you try to correlate central venous pressure or preload with GFR, if this model would to be correct, then it will be more of a linear model. You know, the higher the CVP, potentially, the higher the arterial filling, potentially, and the better the GFR. But that's not the case. It's a curvilinear relationship, meaning that there's a sweet spot. So if your CVP is low, if your CVP is 0, then your pre-renal, your GFR is up. That's given. If your CVP, however, is 20, it's probably worse than if it was 0. See? So it's not linear relationship. So there is a sweet spot. This is another way of looking at this, and this time comparing CVP or preload to cardiac output. If it was true that the reason why patients have worsening renal function in the setting of acute heart failure is because their cardiac index is low, their forward function is low, then you would expect that cardiac index would correlate more with worsening renal function. And in this, at least in this clinical trial, or in this study, that was not the case. You see that CVP correlated better with worsening renal function than cardiac index. In other words, if your CVP is higher, if your CVP is high, your likelihood of having worsening renal function was higher than if your cardiac index was low. It's actually provocative information. The reality is, however, here is that it's usually a combination of low cardiac output, low arterial filling, and elevated renal venous pressure. And this is not a new concept. This is not something that was just discovered in the last 5-10 years, although it has become more popular in the last 5 to 10 years. But this has been known you know, almost 100 years ago. And this was a very elegant experiment where this guy took a dog and ligated his renal vein, and basically demonstrated that the drop in urine output is as impressive with ligating the renal vein as it is with ligating the renal artery. So you get the same level of drop in urine output or rise in urea or drop in blood flow if you ligate the renal artery as you get if you ligate the renal vein. And this experiment is telling you something simple, which is renal perfusion pressure is basically how much arterial filling there is minus how much venous pressure there is. So it's a net product. So if you have low arterial filling and normal venous pressure, then you get worsening renal function. If you have normal arterial filling, i.e. normal cardiac output, but then your venous pressure is really high, then you're going to get the same end result. Is that clear? Why you get worsening creatinine in the setting of acute heart failure? Right. And then, of course, let's not forget that if your patient is, again, 8 months pregnant, male, and your creatinine is rising, and we actually have a patient on the service right now with this, rising creatinine, and not 8 months pregnant, but rising creatinine and very high intra-abdominal pressure, where the kidneys are actually basically congested. As simple as that. I actually call this congestive kidney failure rather than congestive heart failure. And I'll leave you with this last slide to understand the cardio-renal interaction. You know, what is the preload of the heart? The preload of the heart is CVP, right? The afterload of the heart is the blood pressure. Well, think of the preload of the heart as the afterload of the kidney. So if your CVP is high, that's high preload of the heart, but it's high afterload of the kidneys. And then think of the afterload of the heart, which is blood pressure, as the preload of the kidneys. So it's really reversed. So if you keep that in mind, then you can understand next time you see your patient with worsening renal function, what to do next. I'll save this slide to the next talk. So in conclusion, and again, I went over many, many concepts, and I think I would want this lecture to really stimulate your interest in going back and reading some pathophysiology or physiology. I think it's very important. But read about ejection fraction and how it is a measure of size rather than function. Also need to understand the different models of heart failure, how the hemodynamic model doesn't explain all the therapeutic options that we have. You need to read about the Renin-Angiotensin Aldosterone system, and then the beta blocker story is a fascinating story. You really need to read how we now consider beta blocker as gold standard in systolic heart failure. And then, if you're interested, I have a couple of very interesting articles on cardiorenal syndrome and how to address this when you're encountering it in clinical practice, which is very common. All right, I think I'm about 4 minutes beyond time, so we'll pause here.